This is the Nottinghamshire LMC podcast, here to educate, inform and support general practice staff in Nottinghamshire. Get to know about those who represent you, as well as all the latest information from Notts LMC at your leisure. Tune in and subscribe to our podcast today, hosted by me, Zenaida Morrison, at podbean.com. Hello and welcome back to the Nottinghamshire LMC podcast. Today's episode focuses on a very important topic, which is safe working in general practice. What is it? What does it mean? And what should GPs and their practice staff be doing to implement safe working measures in practice? Joining us today for this discussion is Dr. Richard Van Mellaerts. He is Deputy Chair at the BMA GP Committee, and he's also a GP at Fair Hill Medical Practice in London. Thanks for joining us, Richard.
Thanks so much for having me.
And thank you. It's lovely to have you on today and to be having this conversation. I deem it to be extremely important. So thanks again for coming. So safe working, of course, is something that has become an essential thing for general practice to do and to ensure that their patients are safe, and that's the purpose for it. So not just patient safety, but also the well-being of practice staff as well. And as an LMC, we are working on how we support practices to embrace what this means, which is things like capping activity, patient waiting lists, and in many ways, this episode is really the beginning of giving that consent and that confidence and assurance to practitioners to take measures that may be quite difficult to begin with, in terms of implementing, but ultimately would lead to being able to provide better, more sustainable levels of care to their patients. There has been some national guidance, Richard, about safe working, which was released by BMA GP Committee, which we will be following. It will be followed, I believe, by toolkits and case studies as time progresses. And as an LMC, we hope to kind of utilize those resources effectively to support practices in the region. But firstly, there kind of needs to be, I guess, a clarity and an understanding of the guidance, the reason behind it, and then also kind of to go through some of the recommendations and the things that have been suggested. So Richard, I'm going to hand over to you at this point. And if you could kind of give us a backdrop of safe working and talk us through guidance so that practices can get a sense of what it's all about and what it could mean for their practice.
Sure. So I'm Richard Van Mellaerts. I'm a GP in South West London, and I'm elected to GPC England, and I'm one of the deputy chairs. And a big part of my portfolio is this safer working guidance. Now, people say to me, what is safer working? And it's about working in practice in a way that is entirely contractual. So it's within our contracts, entirely within our gift, but it's a way that makes us safer as GPs. It makes our colleagues in all of their different roles in the practices safer, and it makes our patients safer in terms of their well-being and how we can actually make our practices and our workload sustainable again. Because the problem is at the moment that there is demand far outstripping capacity.
Yes.
And our ability to provide the appointments that are demanded is near impossible. So it's looking at what we can actively do in order to try to satisfy that and how to square that circle, because we're not able to really do that at the moment in the present scenario. Yeah. So I've got a presentation that I'm going to bring up, which I'll talk through with you all, which just talks about what sort of things have been done elsewhere, what sort of things have been found to work. And as Zenaida says, we're developing a toolkit. So it's a whole raft of different examples, because it's really important to remember that there is no one size fits all. What would work for my practice in Kingston might not necessarily work in Nottingham, might not work in Wessex or Cornwall or Cumbria. But if we can all share our brains and share all these different ways and examples of that different people have used based on a few fundamental principles, then it can give us a framework around which we can adapt our practices, again, entirely within our contracts, to be able to better manage our patients safely.
Absolutely.
So You'll hopefully be able to see my presentation there. So we're going to run through. So the context is that at the moment, demand is outstripping supply. Patients' needs and expectations have changed. The pandemic have really changed that. We've got a big backlog in secondary care. There are unrealistic expectations and targets that are being set by government. And we're finding that increasingly our practices are on the front line, being put under lots of pressure. Patients are happy, GPs are unhappy, our practice staff and colleagues are unhappy because we cannot currently satisfy these issues. So we need to start to make changes in order to be able to settle things back down to where they should be. So we're looking at these documents here. So that there's workload control in general practice, which has been around for a while. That's talking about different things that we don't necessarily need to do in general practice, how to manage those kinds of demands. And then a safer working in general practice document, which we link to with this presentation. Now, this is being constantly updated. I'm in the process of adding more things all the time to it with colleagues at the BMA. And it's a web page, so you can revisit it and go back there, get different ideas and get different things. And it talks about capping appointments, capping the number of contacts we have, whether or not the waiting list might be something that we look at, how to prioritize workload, getting rid of that external unresourced workload. So what people call secondary care work dumping, how to start managing those kinds of things. Yeah. There's PCN DES, which in some places has been very supportive and in other places not so, and has added a significant burden. So having a bit of a think about that. And there are, there's recourse to things that we've always had access to in terms of thinking about practice list closure and things of that sort. So there's lots of research we're doing at the BMA to look at this, how workload is impacting on people, what the actual real workload is, because the way it's measured is quite crude. So government really measures this in terms of appointments. And you'll obviously realize immediately that so much of the work that you do isn't encapsulated within the traditional appointment system. It's about, when you're staying late, it's often because you're managing documents that are coming through, results that are coming through, patient queries, the tasks and all the different things that sort of coming into our sort of workplace and workstation every day. These are the things that we're not actually very sophisticated at measuring, because actually knowledge is power here. The more knowledge we've got and the more data we've got, the better that we can communicate that to our patients, communicate that to government and NHS England, and steer the system in such a way as to be able to actually better manage our workload and better care for our patients. And really, at the bottom, that point about every practice is different. I mean, that's so true. And and as I say, what I do in my practice wouldn't necessarily work anywhere else in the country, but we can all steal and borrow little ideas and adapt those things because you know best how to manage your practice and your patients. So this is really these are the headlines here. So this is what I've touched a bit on already in terms of measuring our workload and resource work. What is core general practice? That's really crucial. How to prioritize and capping. The capping appointments, this is one that is increasingly being utilized, and it varies very much from practice to practice. So our responsibility in our practice is to provide for the reasonable needs of our patients. That doesn't mean everything for everybody all the time. That doesn't mean limitless capacity every day. It doesn't mean that we have to do everything immediately for our patients. We can prioritize those things that need to be seen on the day, those things that can actually wait a bit longer. And that then means that we need to start to think about how are we managing our duty doctor systems. I talk to lots of duty doctors and they're talking about seeing up to having 100 contacts per day. Now, I don't think any of us can provide as good a consultation with our 100th patient as we did with our first in a day. It just, we get decision fatigue. They've recognized it for years in the airline industry and the haulage industry. They've got caps on their workload. We need to start to apply sensible caps in our practice. Now, we talk about 25 to 35 appointments or contacts per day in your practice. Now, what is a contact? That's a sort of a slightly complex one because, again, this is slightly reductionist because we're really thinking about appointments here, whether that be telephone or video or face-to-face. But limiting those to between 25 and 35. This is based on UMO, which is the European Medical Organization sort of suggested figures. Limiting it down to that kind of level maintains the high quality. And if we're getting beyond that level, then we need to be looking at what other sort of things we can be doing and where else people can be moved within the system locally, not just in the practice, in order to satisfy that demand. So
Sorry, Richard, you said something there which was interesting, and sorry to interject, but about the 25 contacts per day, you said that it could vary. So if it is should I say majority phone consultations, um, does that mean that once they've reached that cap of 25, then that's pretty much the most that they should be doing, or could they have some face-to-face that goes beyond 25?
So how people structure their appointment
Yeah.
books is up to the practice based on their patient needs and requirements, what they feel is best for them. I can give you the example of what we do in my practice. So in
Mm.
my practice, we've gradually reduced the contacts down to 31 per GP per day. Now, that doesn't mean that I'll never see any more than 31 patients. That's a mixture of telephone and face-to-face. So
Yeah.
it's about 1/3 telephone, 2/3 face-to-face. Now, that doesn't mean that I'll never see anybody. So if we have a sick child phone in the afternoon and we're chock-a-block, I'm not going to send them away. I will see them. But what we're doing is we're letting patients know that actually once we've filled our normal capacity,
Mhm.
then they need to have a good reason why they need to be seen that day. So it's not about having unlimited numbers of extras, and equally, it's not about pulling down the shutters. It's about having a system in place, good clinical governance in there. And so this is where I'm talking about things like care coordination and triage, in having that in there, and a triage that changes through the day. So that when you phone up at 8 o'clock in the morning or 8:30, there are a good number of appointments available. But as you go through the day and the capacity is getting filled, the threshold at which a patient needs to reach in order to get into one of those appointments increases. So that later on in the day, you might need to be frail elderly, a child under 5, or palliative care in order to then fulfill the requirement to go into one of those extras or one of those slots. Now,
Mhm.
many practices are pre-triaging their lists. So they're using AI and other forms of automation, or care coordination to go through their patient list to flag patients who are high risk, who will need to fall into those categories. So when they call in, the staff member answering the phone or seeing the email interaction then knows that these patients need to be seen and they need to be prioritized. And if they don't fall into that category, then other forms of review need to be undertaken to decide if they do. This doesn't necessarily have to be burdensome, but
Mhm.
utilizing those kinds of systems, we move away from the kind of approach where, as I say, everything, everybody, all the time, it has to go into everything, irrespective of their priority. But we're reprioritizing based on the resource that we have available. So, and using other providers is an important part of this. Now, many parts of the country have access to walk-in centres. They have access to overflow hubs. And this is about the fact that actually capacity isn't our problem in each individual practice. It is a system-wide issue. When ED is under considerable pressure in my local area, I get an email saying, please consider carefully before you send patients along to us. Obviously, the assumption is that I send patients in the whole time, irrespective all the time. But yeah, but there we are. And actually, that's making ED's pressures a system-wide issue. General practice uh, pressures are a system-wide issue as well. Many areas are using a RAG rating or using OPAL systems and things like that. That's actually really crucial, really important. It can be a real drag for practice to engage with. I've talked to some practices and they're having to do it every day, which they find really burdensome, and other areas once a week. I would always encourage, if you've got access to an OPAL system in your area, bite the bullet and do it. Because actually, if you feed that data in, it's really constructive in terms of giving weight for your LMC to be able to negotiate measures from your local ICB that can actually support practices. Because if you're under pressure, I think a lot of the time in general practice, we just grit our teeth and get on with it. Actually, if we flag it up, say, this is beyond safe levels, demand is far outstripping supply, something needs to be done, then that gives weight to the argument both nationally and locally that there be systems put in place in order to help manage that overcapacity.
Yeah, and I think you said it right, Richard, in that it can be a bit laborious for them sometimes, especially with the amount of sheer amount of workload that we clearly know that practices are have at the moment. So I think that's another place where, as an LMC, we would like to support in any which way that we can. But I think you're right in that it's something to bite the bullet and get done, because it will kind of help them in the long run. But yeah, thank you.
Absolutely. And
Mhm.
all of these things, they do take a bit of time. You know, they take a bit of organizational development. It takes a bit of your practice managers and your GPs in the practice.
Yeah.
Actually, oh, you're gonna have to sit in a few more meetings to decide how to do this. And you know, actually, we're all working so hard, but actually biting the bullet, it's short-term pain for long-term gain.
Mhm.
So as I say, access isn't the problem, capacity is the problem, not your problem. And NHS England are not commissioning sufficient capacity within general practice. So how are we capping? How are we going to do this? So I would say incremental changes. Don't have a big bang where you go from a limitless number of appointments down to a very finite number, but engaging with your patients, talking with them about how you do this. This is where you use your patient participation group. Talk to them. They can be your greatest ally. But remember that the entire country is being fed a whole load of nonsense from all the papers all the time about how general practice, how GPs are lazy and we're sitting around. Whereas, you know, I'm yet to meet a lazy GP. So, you know, engage with them, talk to them about the pressures you're experiencing. Let them know that this will actually maintain your services. By changing the way that you're working, you can make sure that your practice survives and actually is strengthened, and the quality of the care that you provide is greater.
Yeah.
So, and that includes engaging with your LMC, engaging with local politicians. They, you know, if you've got a sensible local politician or a sensible MP, then they can be a fabulous ally with this. Um, Small incremental changes, changing over time. So, as I say, my practice were at 31 contacts per day, which feels a lot more manageable than when it was best part of 40 plus extras a couple of years ago. But it's small incremental changes over time as you develop and adapt your system. And if you can do recruitment, I know that recruitment is very difficult everywhere, but you know, looking at who you're recruiting, how you're recruiting, and but make sure that you're making plans with the sort of access demands in mind when you're when you're making your recruitment plans. The safer working. This is where I age myself, because I like to talk about Zamo from Grange Hill, which who some of you who've got as much grey hair as me may remember. Um, so his tagline was "Just say no." So this is about saying no to unresourced work, that the things that you're being asked to do by other parts of the system which aren't your job. Now they may not get done by other people, but secondary care, community care providers, all of these kinds of people, they're very good at saying no, but that doesn't mean that it should fall on your shoulders to actually do this. So again, measuring your workload, map everything, use the Opal system. Waiting list. Now this is a concept that we've sort of created where well, we've thought about with secondary care. We've been using waiting lists for a long time. For those patients that need to be seen on the day, triage them. They need to be seen there and then. Somebody can wait a week. They can be seen within a week. And then there are those patients that don't need to be seen immediately at all. So they've got an issue where they could go onto a waiting list and be seen at some point in the future when there is sufficient capacity. But considering again how these kinds of things can be applied to your practice is really crucial. There's more details on the website. List closure is always an option. And you know, engage with your LMC with this. They're really the experts in helping support you if you feel that that's something that you need to do in order to preserve the quality of care that you provide and the safety of your patients and your staff. So this is a bit more about that sort of that waiting list concept. So again, it comes back to providing for the reasonable needs of our patients. The 8 a.m. crush on the phones. So there is a bit of a political imperative about this. So there is, you know, there's increasing pressure from the Department of Health and other ministers about this. So we do, you know, thinking about how we start to get away from that. So again, looking at triage, pre-triaging patients, like I've already talked about, and re-triaging people once they have been sort of categorized. So and then those patients that have not got an urgent problem at first contact, it might change. It might get more severe. It might become more problematic. So there's got to be systems in place in order to re-triage them if appropriate.
Mhm.
And yeah, using the wider system is really crucial. PCN DES, again, this falls into my portfolio. And this is something which in some areas has been fabulously successful and in other areas is a real burden. But you know, thinking about the ARS staff you've got within your PCN and making sure they're supporting your core offering to your patients as much as possible. Now, there's all kinds of bits and pieces and extra waffle and fluff with the PCN DES, which we're all asked to do. But actually, if you distill it down, there are only a certain number of requirements that are absolutely mandated. And actually, then, if we can get ARS staff, yes, fulfilling those requirements, but then looking at what they can do in order to support core general practice as much as possible. And this can then utilize that resource if you've got them there, if you've been able to recruit, which I recognize can be very, very difficult, but have them there in order to help support your GP, support your patients. But thinking about the financial benefits, actually the PCN only sort of brings in roughly 10 to 15% of practice income on average. And so, and it's an awful lot of work, not necessarily an awful lot of income. And some practices have made the decision that they will opt out. The future of PTN, so we're going into year 4 from April of the 5-year current framework. And it is likely that PCNs will evolve come April 2024. What that's going to look like, we're going to be entering into negotiations with NHS England soon in order to co-create something which is more practical, which is better, and is better reflective of local variations, because at the moment it's very much cookie cutter, one size fits all approach. Mm-hmm. And well-being of your team is really important. I know we talk about this a bit more these days than we used to, but it's really crucial. And it's worthwhile reflecting, check in with each other, look after each other. Because if we look after each other, we can actually help maintain our practices, maintain our our sense of well-being, and look after our patients more. So there's lots of resources out there, and I always stress that LMCs have great offerings for support and advocacy for their GPs in their area. So do make sure that you're familiar with what your LMC has available to you and work with them on this, because they can be a fabulous resource. So this is just a few lists. This presentation will be available to everybody, but there's a few sort of national different support networks out there as well. So this is all about managing your workload to protect well-being, and it's well-being of you and your staff as well as your patients. You can't look after your patients if you're not there, if you're burnt out, or if you left the profession, you've reduced your hours, you've retired early, or you've moved to Australia. So there's increasing pressure, there's increasing problems with our morale. So if we manage our workload, we can help this. But really crucially, work with our patients. They're our allies. You get them on side, and they can help to really support these kinds of changes to make them successful in your practice. And just in terms of negotiations as we go forward, we've completed negotiations now for 23-24. That's hopefully going to be announced very shortly. It was initially rejected by GPC England because it wasn't satisfactory. It wasn't reflective of the needs of the profession. We're hoping that NHS England will come back with a better offer. And there's obviously negotiations going on in that respect, but that will be announced soon. And then 24-25, there's been lots of work engaging with LMCs and GPs across the country about what general practice is going to be looking like. And so I would encourage you to really engage with that, because we need to hear from every GP what they think that general practice should look like, in order that we can then go and negotiate that on their behalf.
Wow, well, thank you, Richard. That's great. That's a really great overview. And as he mentioned, you will have access to these slides at some point. So you'll have access to the kind of all the recommendations and the websites and all of that. I think, Richard, from an LMC stance, this is definitely something that we deem extremely important for practices to understand and to start implementing. And we hope at some point in the new financial year that we will be having some sort of face-to-face kind of event of sorts that is focused on safe workings. I think it's very important that we do. In the meantime, we personally have published our own focus on. We do these focus on documents depending on what topics are circulating in the healthcare landscape, and safe working being one of them. We actually released it last November, so that's on our website if you haven't had the opportunity to have a look yet. But it simplifies things, it breaks things down for you. And so if you go to www.nottinghamshirelmc.co.uk, you will find that document under what we do under the resources tab on our website. But yeah, so that's one of the things we've done. We've also actually hosted a weekly briefing. So some of our practices who do come to our weekly briefings, it's every Monday at 12 noon. And it's an opportunity to voice your concerns, but it's also an opportunity to discuss matters arising. So I know we have had a weekly briefing where we did discuss our safe working focus on document, which was in line with the BMA GPC guidance that Richard has kindly just gone through. And we just feel that there's a lot more that needs to be done on this. And I know currently our Chief Executive, Michael Wright, is having in conversations with practices who are actually quite keen to start implementing some of this things suggested in this guidance. And it's just to reiterate, it is a process. All practices are different. Not everything that has been suggested is going to work for every practice, but it's about looking through those recommendations and kind of looking at where you currently are as a practice and what you could implement now, and then what you could implement within time. But we're always here. As I mentioned, the LMC are here to support you. So all you have to do is get in touch with our liaison team. They're always on the ground, visiting practices, having discussions with practice managers. So you can contact them via email at liaison@notslmc.co.uk, or you can call on, I believe it's 0115 977 1341. So yeah, that's just some ways to get in touch with us. I think, Richard, now I'm going to ask a few questions that we know our practices would be asking. They would want to know some of these questions. So nothing that you probably wouldn't already have an answer to, but I think this would be a good kind of way for us to document responses of, I guess, frequently asked questions. So do you mind if I
Absolutely. So one of the other things I'm doing is developing an FAQ. So we are planning to publish sort of a Mythbuster, but because I've had lots of similar questions from other LMCs across the country. But yes, fire away, and I'll answer as well as I can do.
Wonderful. Okay, so the first question is in line with, I guess, waiting lists and, capping appointments. What does meeting the reasonable needs of patients actually mean?
So the reasonable needs of your patients is different for every practice, and it is about assessing what you would ordinarily be able to provide and what would reasonably meet reasonable demands. Now, reasonable is a peculiarly English term within our law, which isn't within lots of other countries' law, but it does give us flexibility. I would suggest that it is possible to define your needs, the reasonable needs of your patients, by looking at what your demand is, looking at your list size, your demographics, understanding and benchmarking against other local practices. You can work with your LMC on this. They'll have a lot of data on that. Looking and talking with your PPG and your patient groups about how you are providing services and what they feel is reasonable as well. So it's not something you can really encapsulate into a terribly pithy sentence. I've been trying to do this. You can't really do it, but it is about looking at what would be what a reasonable patient would expect to be provided based on the services that you have available in that practice.
Yeah.
Now, we all have some patients who say, well, I should be able to see you whenever I want. 3 o'clock on a Sunday afternoon, I should have your mobile phone, doctor. That's not reasonable. What's reasonable is that we see a patient within a timely manner for a clinical problem, or for a patient that's ill or believes themselves to be ill, but we get to define how they get seen, when they get seen, based on the appropriate clinical information.
Yeah, and I think that's really good, Richard, that you said the whole engagement and communication with the PPG, with patients within the group, is very important, because it is about having an understanding of what their expectations are, and then also kind of letting them know, okay, so these are your expectations, but this is the reality. And so based on this is what we need to do, because I think essentially that's a great way to get patients as allies, to kind of also be a voice, I guess, for general practice within the community. So I think that's a really kind of good point for that question. Okay, second question. We have no more appointments available for today. Can we signpost patients to other services once we are full?
The short answer is yes. The slightly longer answer is that as long as there is effective clinical governance and some form of assessment in place before you do so. Now, what none of us would ever advocate is that you hit your set number of contacts per day and then pull down the shutters and turn off your phones, and that's it. But that patient that calls in with a sick child when they pick them up from school at 4:30, or an elderly adult or a frail person or a palliative care patient who becomes more ill later on in the day when you're at capacity, you need to have systems in place in order to assess them, decide whether they do need to be seen in addition to your current workload, or whether they can be safely moved to some other part of the system. So should they be calling it NHS 111? Should they be going to A&E? Is it an A&E type problem? Should they be directed to a local walk-in centre or an overflow hub or some other kind of local arrangement that is in place? So it's about being sure that you've got safe systems in place.
Yeah.
Because none of us want to have the scenario where we reach capacity and say, I'm sorry, we can't see you, and a patient comes to a nasty outcome.
So
None of us wants to see that.
Yeah, they have to have contingency measures, isn't it, really? Just in the event that this happens or a patient is severely sick, in comparison to what it was when they first got in contact, this is what we would do. This is how we would act upon that. So I think
Absolutely.
that's very important. Do we have to run clinics every morning and every afternoon from Monday to Friday?
So again, this comes back to providing for the reasonable needs of your patients. So our contracts say that we need to be available to provide care between 8 a.m. and 6:30 p.m. every day. That's it, Monday to Friday. That's our core hours. What it doesn't define is how many appointments you have, how long your appointments are, where they are through the day. And obviously, it's going to vary based on the size of your practice. If you're a large practice like mine with 22,000 patients and a whole raft of GPs, then you can, we have to structure things in such a way in order to be able to cram everybody into the building. But if you're a single-handed practice or a small practice, then it's obviously simply impractical. So it comes back to you defining, based upon the needs of your patients, how you structure your appointments through the day, through the week, in order to provide for their reasonable needs.
Yeah. So it seems like there's lots of different layers they have to meet before that would be kind of a functional, I guess, approach to take, isn't it? That they have to know how they're going to meet those reasonable needs first.
Yeah. So, nobody would ever advocate, just being open on Tuesday afternoon and Thursday morning, that was it.
Yeah.
And I've never come across a practice that would be doing that kind of thing, because actually it's often more of a problem with people working too hard and burning themselves out, as opposed to providing less than they would require. But again, talking to your PPG, if you're keeping your doors open during core hours is something that we do need to do, but there are an increasingly small number of instances where nurses do close for half a day a week, and I think that's something that NHS England are really keen to remove, for good or bad. But they often do that for historical reasons. But structuring your appointments in the way that you feel best meets the needs of your patient, providing the number of appointments that you feel does so, is and again, engaging with your PPG on that. So, looking at them, and if you feel that there's a particular point in the week when you need to provide less appointments and you feel that is reasonable, sense check it. And I think that's really key. But it's got to be locally adaptable based on your practice, because you know it best.
Okay. And I think, I kind of feel like that kind of applies to this question as well, but I don't know if there's anything more that you would want to add. So do we have to have our phone lines on all day?
So there are some variations across different areas with this. And there are some practices which will turn them off for an hour in the middle of the day. I think that these days it's increasingly difficult to do that. Whether our core GMS contract states that we need to, I think that NHS England's lawyers would read it differently to our lawyers. But having, if you are going to be turning your phones off, there needs to be some kind of safe mitigation in place, and safe redirection, or a way of patients accessing care in an urgent situation in order to avoid the sort of scenario where somebody comes to harm.
Right. Okay. Do you have any, well, actually, the next question I'll ask that, because I was going to say, do you have any examples of like things that they could do if, for example, they do have their phone lines switched off at some point during the day, but we'll come to that. How feasible is it for a practice to maintain a waiting list to cope when demand spills over?
It is completely feasible. It is a not insignificant piece of work to set it all up and have the clinical governance in place and have the protocols and systems set up in order to do so and to organise your practice as such. But it is completely legal and within our contracts to do so. Because at the moment there is no mandated for requirement for how fast a patient must be seen. It is simply to provide for their reasonable needs. So therefore, if you have a patient with a very non-urgent, long-standing, non-dangerous clinical problem that can wait 4 weeks, then they can go into a waiting list for that, and they can be seen at that point at which they need to. As long as you are ensuring that there is effective triaging of some sort in place, and the ability to re-triage people that are on the waiting list, and that it would meet the requirements of the CQC. The CQC are there, and they will monitor quality and safety.
Yeah.
So, whilst the CQC are sort of interested in access, it's not one of those things that they directly measure. So some practices have said to me, well, I can't do this, CQC are coming down on me like a ton of bricks if I cap appointments or introduce a waiting list. Actually, no, that's not the case. So I meet with the CQC regularly and discuss this kind of thing with them, and they will say that if you've got effective measures in place, you've got good triage, if you've got all these all the sort of paperwork the CQC love. If you've got that all down on paper, everybody understands it in the practice and the patients understand it as well, and it is safe and it is providing quality care, then that is your locally adapted way of meeting the reasonable needs of your patients.
Yes, no, absolutely. And I think just on that, I just want to say again, reach out to us, the LMC, reach out to our liaison team who are here to support you with things like that. I mean, we obviously have our CQC prep visits and things that we do to support practices already, but I think it's important that if there are processes that you want to put in place, but you feel inundated, you feel like you need that little bit of extra support, reach out to the LMC, because there are ways that we can support you to get this done. This is a really good question, because I find that a lot of GPs tend to, how can I put it? They tend to like having examples of practices who have implemented certain safe working measures, or just generally practices who have done something that has worked for them. So sharing best practice is a way that they tend to learn. So the question is, how does safe working work in your practice, Richard?
So, as I mentioned, I'm in a large practice, 22,000 patients. We're actually based across 3 sites because we look after a university. We currently have a system where, so if I describe my day, I'd have in the morning 14, I'm just trying to count actually. So 12 face-to-face appointments, 6 telephone slots. I then have 2 blocked off slots at the end, which only I can use, which would be if I want to bring in a patient to be seen face to face, I've spoken to on the telephone, or if there is somebody that I need to contact or bring in based on a test result that's come through, or else a document that I've processed. In the afternoon, again, 12 face to face, 3 telephone with 2 blocked off slots again. We also cap our DocMan, so our documents that come through, and also repeat prescriptions. So everybody looks after their own test results. And then DocMan, we limit to a maximum of 20 per day per GP. And repeat for prescriptions, we cap at a maximum of 40 per day per GP. Now, how do we do that? So we do that by having a large number of administrators who will process repeat prescriptions and things of that sort. So we are part of a PCN. So we've got a clinical pharmacist who is wholly within our practice. As a result of that, she manages lots of prescription inquiries and things of that sort. We have a couple of prescription clerks. We also have a pharmacy technician. We've been fortunate to be able to recruit in that respect, but that has meant that we've got a system in place which enables us to sort of manage that. And we also use our other non-doctor clinicians to manage some documents as well. So we take out a lot through systems in place with non-clinicians in the first place. So we weed out those things that don't need an action doing, and that's involved training and support and supervision over time in order to upskill them to the point of being able to do that. Now, there is some flexibility. So if we have, the day or the week or the students come back from their summer holidays, our demand goes up. Or the week before Christmas, like every practice, our demand for repeat prescriptions goes up because everybody's terrified that they're going to run out over the 4-day back holiday. So we flex it a bit. And what we've actually tried to do, so I'm a partner in my practice, what we've tried to do is to really very carefully manage the workload of our salary GPs. Now, partly that is selfish because it is to facilitate recruitment and retention. Salary GPs are working to a defined contract, and that, in a job plan, that would often define how much workload they'll be having in terms of repeat prescriptions, etc., etc. But so we've made the decision as partners in my practice that we will flex. So there'll be some times when I actually have less repeat prescriptions than somebody else, but there'll be days when I'll have considerably more. And the same with my other partners. So it's about having a sensible approach, which is clearly defined, but then having a little bit of flex around the edges. But if you're flexing all the time, then you've probably not got it quite right, and it needs a bit of tweaking. And it's taken us a good couple of years to get to this point, so it's not overnight.
I was gonna say, how long did it take you to get to this point? But yeah, so it's once again, I think what you're saying is it is work in progress. It's about finding what works for your practice, because every practice is going to be different. And I think you do have, I guess, the benefit of being able to employ more staff, whereas it probably wouldn't be the case for another practice. So yeah, once again, there are different suggestions within the guidance. Not everything's going to work, but some things will, and it's going to take a little bit of time to begin with to get up and running, but ultimately for patient safety and well-being of staff. So it's still a very pivotal thing to
just to sort of add to that with the staff component.
Yeah.
This is where you can leverage the PCN desk. So utilizing the digital and transformation manager, care coordinators. Now, I think that those two roles in particular are brilliant because they're nice and ill-defined. They're very vague and very woolly. So it means you can make them what you want them to be in order to help support your practice. And so you can have these people doing all kinds of things, even the GP assistant role, which was brought in recently. Flex it, be as broad, be as creative as possible. It's really about, ask for forgiveness later. Act now, ask for forgiveness later is really crucial, because I'm seeing lots of really innovative examples of how practices are using these kinds of stuff to support that kind of workload, which can make the GP's life more manageable.
Yeah. Thank you. No, I think they need to hear that from you, Richard, actually. So no, that's great. Can we turn off online triage?
So this is another one of which I think NHS England and the BMA and LMCs would differ on. So I'm aware of lots of different ways of going about this. So some practices have managed this by hiding the link on their websites. Now, they may not advertise that fact, but it may not be terribly easy to find. Now, online triage can be a sort of it can feel like you're being inundated with requests. Now, there are legal questions in this, and there are sort of still legal elements of it that are being bottomed out. But some areas have considered that they simply turn it off overnight, or they turn it off outside of core hours. As a way of sort of managing that. I'd encourage you to engage with your LMC if you're considering that, because that can be an effective way of helping to manage that demand. And so whilst we are obliged contractually to provide access via online means to our to our services, it's not necessarily clearly defined in exactly what way that is. So there's lots of different ways of going about this. So I would say, again, this is one of those locally adaptable means where you work with your LMC, you can see what the sort of the expectations of your ICB are, and see how you can provide within the requirements of the contract, whilst not just opening up an unlimited demand component.
Right. Okay. Two more questions. We get more demand through online consultations and feel like turning the tool off. Can we do this? Is it okay just to offer an email address?
So I think that an email address probably wouldn't fulfill the requirements of our contract. So it does talk about sort of online means of consulting. So I think an email address would probably not satisfy that. But equally, it doesn't say that we need to give completely unfettered access via those means. And if we can demonstrate that the demand that is being encouraged by that route is unmanageable and unreasonable, then I feel that we can take reasonable measures. Again, I would encourage you to engage with LMC on this, because they'll be able to give you the sort of the good, practical, on the ground advice in order to mitigate that. Because otherwise, I'm aware of some practices that have had such enormous demand from this that they can barely manage to provide anything other than just sit there and go through e-consults every day, and that's just it actually degrades the quality of the other services that you provide. There's also arguments about it disadvantaging those that don't have easy access to online services, because who are those patients that need us the most, who have the highest needs, and those are kids, the elderly, palliative care, and those with long-term conditions. Those are all groups that are going to find it probably more difficult to access some of these online tools. So therefore, we need to make sure that actually the needs of those groups are being prioritized, because they have the greatest need.
Yeah, very good point. Last but not least, will we breach our contract if we say to our patients that we cannot fit anybody else in to be seen on a given day?
So again, there's a short answer and a long answer to this. So the short answer is no. You won't be in breach of your contract if you say to a patient, no, we do not have capacity to see you today. What happens after that is quite crucial, and what happens before that answer is given is quite crucial as well. So again, this is about not having a hard finish and you bring down the shutters and say, we've had our 25 contacts per GP, that is it. If you have effective, demonstrable processes in place that can assess the needs of that patient that is contacting you when you are beyond capacity, and you have demonstrated that you don't need to provide capacity or the extra capacity to meet their needs at this moment in time, i.e. they've got a low acuity problem and they're calling when all of your normal slots are full, and it's something which can safely wait for later. I would say that it's often best if you can direct people to another service or find a way of putting them into a waiting list or something else of that sort, as opposed to please phone back again tomorrow, because that doesn't necessarily do anybody any favors. And so, starting to think about ways of evolving away from, I'm not saying don't ever do that, but I think that we need to start thinking of developing systems which enable us to evolve away from doing that.
Yeah.
But this is where, having done the prep work beforehand, having worked with your LMC, your local area, to develop other system-wide issues, making sure you've got those safe triaging systems, care coordination processes in your practices, you've got the good clinical governance, that then puts you in a position where your patient calls in, they're assessed by a care coordinator or whoever, and then say, well, you've not got a problem which needs to be added into the already full capacity that's in today. So therefore, this is the other way that we are going to manage you, i.e. you're on a waiting list, call back tomorrow, please go to the walk-in centre, go to your local pharmacy or whatever.
Yes. Well, that has certainly been informative. I feel there's definitely more clarity on safe working. So thank you very much, Richard, for joining us today and sharing that with us. I think also there's that whole aspect of, the patient engagement, patient communications. And like I said, as an LMC, our doors are always opened. We're we have been working and we are working with Health Watch to kind of look at different patient-facing campaigns that, can spread a little bit more information, even just as far as, additional reimbursement roles are concerned, and just different avenues of care, just to take some of that pressure off general practice and to make sure that GPs can provide that quality of care that they do, and they're so used to providing to their patient population. Our liaison team, as I mentioned earlier, would be the first port of call, and they can be reached by email at liaison@notslmc.co.uk, or you can get them on 0115 977 1341. Richard, how can practices reach you should they wish to discuss safe working in more detail?
So I'm very happy to be emailed. My email address is rvanmellaerts, so RVANMELLAERTS @bma.org.uk, or I'm on Twitter @Van Mellaerts. So tweet at me or email me, and if I can't answer your question, I can find you someone who can.
Wonderful. Thank you very much. I'll put that on the show notes for sure, so you'll have those details. That is it for this episode. Always a pleasure coming your way. This episode will be posted on our usual platforms, as you know, Podbean, Spotify, Apple and Google podcasts. But also, because we've recorded it as an audiovisual, it will be hosted on our YouTube channel as well. So I think if you go into YouTube and you type Nottinghamshire LMC, you're likely to see it. So that will be uploaded, and we will be updating you and letting you know when it's up for you to watch. So thanks once again, and until next time, it's bye for now. Thanks for listening. Be sure to subscribe to the Nottinghamshire LMC podcast for subsequent episodes with me, Zenaida Morrison, at podbean.com. Bye for now.